Welcome to JPAL's Idea Handbook webinar series. I'm Iqbal Dhaliwal, the Global Executive Director of JPAL and a co-chair of JPAL's Idea Initiative. These webinars accompany the release of the Handbook on Using Administrative Data for Research and Evidence-Based Policy, funded by the Alfred P. Sloan Foundation. The handbook provides a series of technical guides and case studies on how to make administrative data more accessible for research and policy. Today, it is my pleasure to introduce my friend and colleague Laura Feeney, the Associate Director of Research and Training at JPAL North America. Laura will present the chapter she co-wrote with Amy Finkelstein, who is a professor of economics here at MIT and the co-scientific director of JPAL North America. Laura is presenting her chapter from the handbook titled Aurora Healthcare, Using Electronic Medical Records for a Randomized Evaluation of Clinical Decision Support. This case study features a large RCT conducted using administrative data that showcases the partnership between JPAL North America and Aurora Healthcare, in which research questions and data access were negotiated collaboratively and priorities of each member of the partnership were carefully considered. From working with a data provider to identify research questions, to accessing data, to conducting an RCT, and publishing results, this is a case study in a successful admin data partnership from start to finish. Following the talk, we will have a live question and answer session, so please do post your questions during the presentation in the chat box right below the video, and I will discuss these with Laura after her talk. With that, I invite you to listen to the webinar. Thank you.
Hi, my name is Laura Feeney. I'm the Associate Director of Research and Training at JPAL North America. I'll be sharing a case study of using administrative data from Aurora Healthcare's medical records to evaluate the impact of a clinical decision support tool for radiology imaging. Amy Finkelstein was a co-author on this case study, as well as the underlying research project. And I'd like to also recognize the other co-authors from that original study: Joe Doyle, Sarah Abraham, and Aurora's Dr. Sarah Reimer. I'll start by giving background on the research project itself. Then I'll outline challenges in getting approval and access to the data, and then we'll follow up with steps we took to make the data usable for research. Then I'll talk a bit about data security coupled with data publication and what made it possible for us to publish a public use dataset. And I'll conclude by sharing some key factors that we think really enabled this project to be successful. In 2014, the Centers for Medicaid and Medicare Services, or CMS, announced that starting in January of 2017, they would require the use of a clinical decision support tool prior to ordering certain types of radiology imaging, things like MRI and CT scans. This was motivated by the high level of spending on such scans, and a belief that many scans were unnecessary, or perhaps would lead to additional unnecessary treatments. By the time we started the study, the implementation date was pushed back to 2018, and it's since been pushed back to 2022. At the time, there had been observational studies of CDS systems, but there hadn't been large-scale randomized evaluations. So there is interest in understanding how to make a CDS system feasible and how much of an impact it might actually have on radiology ordering. Clinical decision support, or CDS, tools provide information about the appropriateness of images based on guidelines from the American College of Radiology. These are essentially pop-up alerts called best practice alerts. They're designed to tell a provider whether, for a given patient's age, sex, and a given indication, so things like headache or backache, a scan is usually appropriate, sometimes appropriate, or usually not appropriate. The tool can also show alternative scans that may be more appropriate. We designed a study with the Aurora Healthcare, which is the largest healthcare provider in Wisconsin. In addition to their healthcare work, they host the Aurora Research Institute, which is committed to supporting research that leads to new and improved ways to care for people and manage community health. They were planning to implement CDS anyways, in order to prepare for the CMS mandate. By working with researchers, they could also gain insight into potential impacts of the tool, both at Aurora and have results to share with the wider research and health community. Dr. Sarah Reimer led the project from the Aurora side, She's a radiologist as well as a researcher. She helped to coordinate and gain internal buy-in at Aurora, navigate the research bureaucracy, and provide insights into the radiologist perspective. From late 2016 until late 2017, we ran a randomized evaluation with over 3,500 of Aurora's healthcare providers. Half of them were randomly assigned to receive the decision support tool, and the other half would continue to order scans as usual until the study period was over. Here's a partial image of what this clinical decision support tool, what this pop-up actually looks like. This is the top part and shows the selected scan, its appropriate rating, the age and sex of the patient, and any alternative scans that would be more appropriate. We don't have permission to show the bottom part, but this part would allow the provider to either continue with the original order anyways, or place one of the alternative orders, or cancel out of the pop-up altogether and start over. We were interested in understanding whether providers would make different decisions once faced with this pop-up alert. Would they place one of the alternative orders instead? Would they order fewer scans that would trigger this pop-up alert? Would they eventually get used to this pop-up and ignore it more as the study went on? Or would instead they learn which scans were more appropriate and order those from the start? To measure the difference in ordering patterns between treatment and control providers, we really needed the administrative data from the electronic medical record and order entry system within it. Surveys would be impractical and imprecise, and this intervention was already built into the same system that could provide the data. Data from Aurora included providers' demographic information, as well as information on patients, healthcare encounters or visits, scan orders, and sort of clickstream data of how the provider interacted with that pop-up alert. Most of the data came from the electronic medical record in Epic. I'll talk more about Epic shortly. Some data also came from the National Decision Support Company, which built the CDS system that integrates in Aurora's EMR. This included things like whether the pop-up alert displayed and what alternative scans were offered. We had this data retrospectively for about 8 months to be able to understand baseline ordering patterns and select our study sample. We got data on a rolling basis throughout the study period. Next, I'll move to some of the data sharing challenges under 3 broad categories of cost, complying with the HIPAA privacy rule, and data use agreements. The first is cost. Maintaining healthcare data for administrative purposes, even before thinking about research, is costly and time-intensive. These data are also very valuable as they unlock the potential for many types of research. Leadership at Aurora recognized that their data were valuable and had some concerns about giving it away for free. With our radiologist collaborator, and with support from other key leaders in the Aurora Research Institute, we advocated for the value of the research knowledge gains that would come out of this, and the value of collaborating with the MIT research team. In addition, we did have funding for this project from the Laura and John Arnold Foundation, now known as Arnold Ventures. We established a sub-award to support Aurora's work and effort in completing this research project. This included support on a cost-reimbursable basis for Aurora's data team, compensating for the time that was directly attributed to preparing, extracting, and cleaning data associated with this study. The next major challenge was HIPAA, the Health Insurance Portability and Accountability Act. The privacy rule aspect of HIPAA regulates the sharing of health-related data generated by healthcare providers like Aurora. The HIPAA privacy rule is very complex. One can be an expert in aspects that relate to healthcare administration, but have little familiarity with the aspects related to sharing data for research. There can be serious consequences if you mishandle HIPAA-protected data, and some HIPAA requirements can be onerous. This tends to make university legal teams, as well as hospital legal teams, very wary about sharing data that's protected by HIPAA. The privacy rule defines 3 levels of data, from research identifiable data, which involves many requirements from HIPAA, including a data use agreement and security measures, to de-identified data, which is not protected by the privacy rule and therefore does not have any specific requirements. In the middle is a limited data set, where a specific set of direct identifiers are removed, but there may still be some risk of re-identification. Aurora and its component hospitals and clinics, as well as MIT, were more comfortable using only de-identified data, as it would simplify the contracting process and allow us not to worry about HIPAA. We used the safe harbor method defined by HIPAA to create the de-identified dataset. This requires removing 18 types of identifiers enumerated by HIPAA. One of the key implications of this is that all elements of date except year must be removed. The last stage in setting up data sharing agreements was the approvals and agreements themselves. The first step was getting research administrative pre-authorization from Aurora. From there, we worked on getting IRB approval and setting up a fairly simple data use agreement. Once our prime award for the project was in place, we also set up a subaward with Aurora, which contained additional provisions relating to the data work. As a part of the subaward negotiation, we also negotiated to be allowed to publish an aggregated public use dataset and agreed on general terms for that dataset. This process took a great deal of time, edits, and clarifications from each side, and some negotiation and compromise. Once we had completed all of those steps, we started to receive data and moved into figuring out how to make the data usable. 3 main areas of work involved were identifying the relevant data and then extracting it from the system, understanding and interpreting data, and creating a linked panel dataset while complying with the standard of MIT receiving only de-identified data. So here's where we return to Aurora's electronic medical record system. They use the Epic EMR system, which is the most common in the US. It includes an industry-standard radiology information and order entry system. It covers many aspects of healthcare administration and medical records. ACR Select generates the data and the alerts in the pop-ups themselves. It integrates into the Epic EMR system, and I think also into other standard medical record systems. Epic and any integrated programs or add-ons generate and store data in a relational database structure using some kind of SQL database. With this structure, tables are designed with primary keys and foreign keys to make linkage between all of these tables straightforward. The challenge lies in finding the right data. Documentation from another hospital's Epic system says they have 18,000 tables. Lots of this data is used to generate and run automated processes. It's logged and stored, but typically isn't used afterwards. There's just no business reason to look at it. Documentation is oriented to the administrative use of this data rather than to giving enough information for an external researcher to make sense of it. As an example of identifying data, we wanted to confirm through the data whether this BPA, that pop-up screen, actually showed up for the treatment group and did not show up for the control. There had never been a business case to look for this kind of information before, so analysts at Aurora didn't know whether these data would exist, and if they did, how to really interpret it. So the MIT and Aurora data teams worked with NDSC, the software developer, to confirm whether and where these data would exist and how to use them. This leads into understanding and interpreting the data. In addition to documentation, we really relied on relationship building. We made several visits as a team, and one of the co-authors made several other visits on her own. In these visits, we directly observed various healthcare providers interacting with the EMR. We watched them ordering scans in different settings and asked them to walk us through their typical workflow of ordering scans and what they do with pop-up alerts, observing and discussing the order in which providers entered data and how they move through the screens of pop-ups also enabled us to better interpret patterns in the data, such as how a canceled scan order might appear. Initially, we had thought that providers would enter a scan order, see this pop-up, learn there's a much better scan available, and use that pop-up interface to change the new scan. We learned from a few providers that it was more common for them to close out of the pop-up and then manually cancel the scan and manually enter this new scan. This made it a bit harder for us to figure out the impact of the pop-ups and whether ordering behavior had actually changed as a result of the BPAs, and sort of in what way. Next, we had to figure out how to create a panel dataset with only de-identified data. The Aurora team was allowed to see all of the original data, including the identifiers, since they work directly for Aurora and this is a part of their regular duties. Even while on site, the MIT team was never allowed to see this raw data or interact with the system directly. So we receive data on a rolling basis, at first biweekly, and then we moved to monthly. So we needed a way to create a stable and anonymous patient and provider ID in order to link records. Not just a single extraction and de-identification, but a replicable process that could be done frequently and where new providers or patients might be added in later extracts. The co-author team had previous experience with a data provider de-identifying data by perhaps copying it into an Excel sheet and creating a random number through a pretty manual process. Sometimes the numbers would change if a new provider or patient came in, likely something to do with the sort order. We wanted to be sure to avoid this situation and have a process we could rely upon to produce the same de-identified ID for the same provider with each data extract. We worked closely with Aurora to provide as much support as we could. We provided explicit guidelines and pseudocode or template code wherever we could. We brainstormed how to run checks to ensure that the process was stable and replicable. The Aurora team created a surrogate mapping process. Here's a bit of a visual to describe how we ended up doing this. I've added a bit of extra data to the table to make it hopefully slightly easier to understand. So, from the original Aurora data, we would have the source system identifier, labeled here as the provider ID. This would be considered too close to identifiable to be shared. The mapping process populated a table with one column for the source system provider ID and another column with the surrogate ID, labeled here as the anon ID. This was produced by a random number generating procedure within SAS. With each data extract, every ID that is extracted from the source data is merged into the mapping table. If an ID does not match an existing entry in the table, the provider ID is inserted, and a new, unique surrogate mapping ID is produced for the source ID. So this orange data set on the top is from January, and we have 3 providers. That's the first version of the mapping table. The extract in February has another set of 3 providers. The first 2 had merged with the master list from January with no problem. Nothing added or changed about their anonymous IDs. The third is new, so it would be inserted into the table and a new ID created. Next, we had to deal with not having exact dates, but wanting some information on the relative sequence and time period of orders. For example, if a scan was from the pre-intervention period, or which quarter of the year-long intervention period it was in. This would give us insight into whether and how ordering patterns changed over time due to the pop-up. Our solution to this was to create a patient-specific reference date. This date was not shared with the MIT team. Then each date variable was converted to the number of days difference from that reference date. Doing research without access to raw data like dates or identifiers, and without direct control over the de-identification process, and without directly controlling the process of random assignment and delivering the intervention, required a lot of trust. And while we offered as much support as we could to Aurora, a lot of time and mental effort was needed from the Aurora analysts. The subaward had accounted for funds for the analyst's time. This allowed commitment at the institution or department level to allow the analysts to use their time on this project. But this doesn't necessarily motivate people at the individual level. They're salaried. So this trust was built up through in-person meetings and through weekly or biweekly phone calls. It also helped to have a shared incentive in terms of doing research and learning about new data analysis methods. Some analysts really went above and beyond the duties they might have done in a typical day at Aurora. For example, they learned how to do fuzzy matching and learned about using edit distance for matching in order to test whether there were duplicate patient or provider records. That is, the same person but with 2 records on the hospital side. Finding these people who were not just assigned to do the job, but were also interested in it, I think really helped with fostering trust and ultimately success on this project. Now I'll talk about data security and data publication. As I've said, MIT only ever had access to de-identified data. Even so, we took care to protect the data in transfer and at rest. Data was shared via SFTP and was stored on a secure encrypted server maintained by the IT team at the MIT Department of Economics. Access to the server goes through an encrypted secure shell protocol that requires connection to the MIT network or MIT VPN. That network utilizes an independent authentication system. Data sharing was set up explicitly to do this research. So the agreements acknowledged and permitted the publication of scholarly work based on the data that was shared. That is pretty typical in my experience from other research projects that involve administrative data and data sharing. What went a bit further was that we were also able to get permission in advance to publish a public use dataset that would enable replication. Aurora wanted this to be aggregated to the provider level rather than scan or patient level data, but we were still able to publish enough that one could replicate the results. We had a 30-day review time frame for Aurora to review the academic paper and the dataset for disclosure of identifiable information. Lastly, I want to reiterate some key factors for success. Much of the success of this data sharing and research collaboration was due to clear communication, strong relationships, and patience. The frequent in-person meetings helped us to develop a rapport with the Aurora analysts, which fed over into better communication over the phone or by email. This contributed to trust and to developing a shared vision and commitment. We also had strong interest and backing along the way from some leaders at Aurora's Research Institute. They were interested in continued collaboration on research and in further elevating Aurora's reputation in terms of doing high quality and interesting research. We had initially hoped to build off of this relationship and conduct more research leveraging the existing collaboration, data sharing structure, and partnership. However, circumstances changed a bit. Two of the key executives that we had relationships with left the Research Institute. Then Aurora underwent a merger with Advocate Healthcare. This really changed some of Aurora's institutional priorities at the time. More recently, COVID-19 has likely continued to disrupt the typical priorities of the healthcare system. We do have other JPAL-associated researchers who are trying to start up projects at Aurora. The ultimate result is a bit unclear at the moment. Thank you so much for your attention so far, and I look forward to seeing you in the live portion of this webinar.